well, welcome everyone to our final session. Let's give a round of applause for that. It's been a great day, and we really appreciate you choosing us over the next Victory Parade, and also for coming to this last session. I want to thank also our distinguished panel up here with me today. So our objective today is to unpack the affordability playbook, and we know that value-based care, it includes many different types of strategies, and they all have different ways to approach total cost of care, clinical quality, and member experience. And today, we're gonna talk about the intersection of a few strategies that are very popular, including centers of excellence, advanced primary care, and specialty networks. So to set the stage for our conversation, I wanted to share some recent Aon Health survey data from our self-insured employers, as well as other different clients and prospects across the board. And so what we're seeing across the board is a trend towards steerage to high quality providers. And it comes in many different flavors. One of them was, you heard from Steve at Gartner on steerage to high performing physicians as part of it. Centers of excellence, one of our topics today, is also extremely popular. So our most recent data showed that when centers of excellence are implemented on a voluntary basis, 29% of employers have implemented it for 2026, and 26% are considering implementing the next 1 to 2 years. So overall, 55% of self-funded employers are either doing or considering this option. Now, on a required basis, we're seeing 9% of clients have implemented it, and then 24% are considering it for the future. A second big trend we're seeing is around primary care. I consider it getting back to the future on primary care and really doubling down on the fostering the relationship with a PCP. Our data showed that 22% of self-funded employers have an on-site or near-site clinic today, and then an additional 8% are considering it for the future. So with that as a foundation, let's go ahead and jump into some questions. So I'll start first with Dr. MacLean, and then followed by Dr. Vakharia. So we wanted to know, as we group advanced primary care centers of excellence and specialty networks in together as value-based care strategies, what does each of them do where they perform best, and what are some areas of opportunity?
Great. So nice to be here today. I'm Kathy MacLean. I'm the Chief Value Medical Officer at a hospital for special surgery, which is an orthopedic hospital on the Upper East Side of New York City. We're, I think, widely regarded as the highest quality orthopedic center in the US and possibly the world. So quality is a really big deal for our hospital and our clinicians. And we do participate in a number of Center of Excellence programs. As you know, Aetna has a program, Blue Cross Blue Shield has a program. There are various other entities, employers who have programs, and we participate in various ones. I think that what the employer gets out of sending patients to a Center of Excellence is higher quality care. So we're an orthopedic hospital. We're going to get the job done well. You're going to be much less likely to see your beneficiaries being readmitted or needing to have revisions, or it's just not kind of working out well. I think that one of the things that you miss in this fragmented health system of ours is that I think one of our largest value levers is the fact that we don't do unnecessary stuff. So we survey every patient that comes to see us that's going to have surgery and ask them, who referred you, why are you referred here, and had some, what did the last person say? And they, 30% of the time when someone else had referred them for surgery, someone else had recommended surgery, 30% of the time our surgeons say, no, you don't need surgery. And so let me tell you, that's a much bigger cost saver than preventing a readmission. I mean, we want to prevent the readmission, of course, or complications, but that's, I think, really where the biggest bucket of savings is. And I think in our fragmented system, we miss out on that.
Great. Dr. Vakharia?
Thanks, Patti. So I'm Nirav Vakharia. I'm a primary care physician and also work at Marathon Health, where we are going back to the future and primary care. So that also makes me Marty McFly, perhaps. But I wanted to sort of dovetail on what Kathy was talking about. Primary care, you all know it. You know what it looks like today, but maybe pause for a second and ask yourselves, what should it look like? And it should look like that platform onto which best-in-class solutions like a hospital for special surgery or like a Lantern or like a Carrum can attach so that that patient, most importantly, has that seamless and integrated experience, even if they're passing between providers. And so that's what it should look like, but of course, we all know what it does look like today out in the community. Hence, what you might sort of look to explore is opportunities where it's getting back to its roots. They're going back to the future as was described in terms of highly accessible, like you can get in that day if you want to with your provider, someone who knows you and someone who's thinking about you between visits, and someone who's working as part of that broader team, both inside of the health center as well as beyond, in order to get you that seamless and integrated experience. And that's what advanced primary care is, and it is fantastic at prevention. But when catastrophes happen, like the need for a surgery or a cancer or a heart attack, that's where you also want to sort of leverage its capability for coordinating that care, getting people to the right place, and getting them back when that episode of care is over as well.
So that's great. I think that aligns with what we see at Aon too, of that the care coordination aspect of both advanced primary care and with specialty networks to make sure it's appropriate care to even begin with, to your point. I think that's great. All right, if you had to prioritize, I'm going to pick on Christoph next. So if you had to prioritize primary care redesign, high-cost episode management with high-cost claimants, and then network steering, where do you see the most meaningful ROI come from? And then how should employers decide where to invest?
Yeah, I mean, if I think about the return on investment, right, I have a lens on specialty care, right? That's what we work in. That's about half of your spend, probably about $8,000 per employee per year. And I really see two parts of what ROI is, right? The first part, Dr. MacLean already talked about, right, is let's make sure that the specialty care actually needs to happen, right? The best specialty care is the one that doesn't need to happen, where there's more appropriate, where there's similarly effective, right, less invasive option that's available. And we see very similar numbers across our network. Of course, HSS is in there, but the 30% is what we see in our data too. That is the first part of ROI, right? Somebody's been told you need a surgery. Yeah, your knee doesn't look good. Let's get it replaced. And if you have a high quality, very appropriateness-minded physician look at this, they might say, oh no, you're fine. Do some exercises, right? And now you're doing maybe $2,000 worth of PT as opposed to spending $50,000 on a major surgery. Right? Value is there, and of course, recovery is much, much faster for the employee or dependent. That's one part of ROI. I think there's more ROI to be had, right? The other aspect is when the procedure does need to happen, as a purchaser, it's really important to focus on what is the most cost-effective way to get the procedure done in a very high-quality fashion, right? And there's a lot of ROI to be had in that one, too, because healthcare is a really weird thing. Healthcare is not like, how much does the price between two gas stations really vary? Not a lot generally. Well, in healthcare, it actually varies a lot. And you can find very high quality care at very affordable prices if you know where and how to look, and if you know how to structure the incentives with the providers in the right way. So in addition to avoiding very invasive and costly care, when the care does need to happen, you can save around 40–50% of the cost of that too. So when we look across our employer book, it's about 50–50, right? The savings for more efficient care and the savings for more appropriate care.
So I'm curious, so Dr. Vakharia, from a primary care perspective, what are your thoughts on ROI?
Well, from a practitioner's perspective, I love our title. It's real ROI. And I would challenge us to think about what does the R in ROI really mean? We're probably all coming at it from a dollars and cents perspective, but there is a broader societal opportunity here to define return, right? So for an employer, a lot of the employers we work with, absolutely you got to get at least the one-to-one on the financial side, but very important for them also is this is a way for us to attract and retain great talent in our organization by making sure that they have access to free and high-quality healthcare. Or they may talk about the need to just express their values as an organization, and this is a way they can express those values by caring for people and getting them access to a needed service that unfortunately may not exist in their community. So there's all sorts of, I think there's a broader perspective on the return, but of course at the end of the day you have to defend the investment. And what you'll see in primary care, and this is 50 years of evidence, this isn't me making stuff up here, but this is like 50 years of high quality evidence basically saying primary care is a wonder drug. And it doesn't matter who you get it from, just get more of it. There's a great dose response curve. The more people use it, the less they go into the hospital, the less they see specialists. The more they report their self-rated quality of life is better, the better their chronic diseases are managed. And in fact, the longer they live, there's a true mortality benefit to it as well. So I'd put all those things in the category of the R in ROI as why sort of primary care should be somewhere, and ideally at the foundation of a strategy to sort of get a better handle on the healthcare cost that you all are bearing.
Great, so thank you. It sounds like from a primary care perspective, there's more of a long-term perspective, really short-term and long-term perspective of cost savings, quality, and member experience. I would say then from the COE perspective, quality and efficiency are key parts of that. All right, great. So as we think about these different strategies, sometimes a lot of employers ask, is the care ultimately for employees going to be coordinated, or is it more siloed or fragmented care? So, Christoph, start back with you. So how are you seeing these models either being more coordinated or more fragmented? What's your perspective on that?
Yeah, I think you had asked me this question maybe 8 years ago. It was much more fragmented. The world has really moved on, and I think it's really been, purchasers like the ones in the room really pushing the vendors that sit here to really work together and really provide this integrated care. And I want to give 2 examples where I've seen this work really well recently. Example 1 is a large employer that has a very robust advanced primary care model in place. So the kind of things, Dr. Vakharia, you're talking about, they have that in place. And so we sat down with that advanced primary care model and said, well, at some point, right, you may have to refer to specialty care, right, be it cancer care or behavioral health or orthopedics, cardiovascular, et cetera. How do we make it a seamless linkage, right, so that then you come from the primary care into the Center of Excellence network? And so we set this up with that employer, and it's wonderful, right, because the employee now they don't have to think about, oh my gosh, there's so many things they have to keep in mind. It's pretty seamless, right? A single sign-on, they just, there's one transfer, so it's very easy for them to use. That's one area where I see this becoming more integrated across the board. And another area I see this becoming more integrated is in the navigation space. We have embedded partnerships with a number of navigators like Carrum Health and others where it's similarly tightly interwoven, right? Where it's like, okay, patient calls, all right, if we're talking about orthopedics, this is where you go next. And so that's really picked up over the last couple of years where a lot of purchasers now demand of the vendors, I think rightfully so, to make it the seamless experience so the employees have to deal with a concoction of different vendors.
I think the experience is becoming more and more critical, and we even heard AI part of today, how to make the experience better, and I think it relates to our conversation today as well. So Shelly, I'm curious from Lantern's perspective, what do you think is working and what's not?
Yeah, I think it's a great question, and I agree with Christoph that the fragmentation has come down a little bit. I think benefits leaders have recognized that the days of COVID and the height of very rich benefit plans and more is more has kind of come back a little bit, and we're seeing a lot of employers being very scrutinous of partners that can really determine and deliver that real ROI. And so I think the other thing that needs to layer on top of that, somewhat of a consolidation we're seeing, is really how do you market these benefits to your consumers or your employees? I think what's missing today, and I think one of the questions, Patti, that you had asked us is what isn't working, and that is healthcare marketing is still a little bit in the dark ages in terms of how you drive consumerism and get people to adopt these benefits. It's confusing and it's overwhelming. And when somebody joins a new role or gets, going through OE, there's just a lot to consider. And so another, I think, side benefit of some of the consolidation of the benefit plans we're seeing is a narrowed focus for your employees to really understand what are you offering and how can they and their families take advantage of it. Because at the end of the day, it's about how many people can you help. And if your employees don't understand what you are offering and why it matters to them, it's just hard to see the adoption that you need. And so I think one of the things that we focus on at Lantern is, this is not just an internal comms motion. This is a performance marketing motion to really drive awareness, to really drive consideration, and to build that trust through the funnel so that when it comes time for needing, help with an infusion or surgery or cancer, that members feel supported and that they can trust the guidance to ultimately lead to an avoidance. As the panel said, that is the number one positive outlet. But in the event that something is needed, that they understand who to go to and why. I think the announcement that we made this morning with our partnership with Marathon is a perfect example of where that works really well. It's hard to imagine a more trusted referral than a primary care physician in those moments. Lantern is embedded into the EMR at Marathon. Their care teams are trained on the quality of our network. They know that if they can send their patients to us, they're going to get a better outcome. And so that seamless integration, it's one less thing for the member to have to think about or do. And they know that they're in good hands and that they can kind of be shepherded through that system. That feels very good. And I think it's a really good example of where two great benefits are working together on behalf of both the member and the benefits team.
Well, congratulations on your big announcement. I'm glad we could provide a forum for that for to spread the news. I think it is interesting to see how your two organizations have partnered together to bring the primary care and specialty together. So Shelly, as you were talking, one question that came up in my mind was around, a key part of any of these programs is how do you steer people away from where they're going today that may be poor quality to high quality versus listening to their next door neighbor's recommendation or even asking ChatGPT, which we know studies show is pretty high for getting recommendations. So I'm curious, what are you seeing as strategies that actually help people steer to high quality and these pathways?
Yeah, it's a great question. I think, like we said, ultimately this is about how many people can you help, and I think that steerage is so critical. So the first thing, I think one of the most valuable levers that you can do as the benefits team is to waive that cost share for the member and to really give them that incentive to consider an alternative path. I think, really consumers and employees and patients, they don't always want more choice, but in the absence of knowledge, they feel like that's better. But if we can really educate them and show them an incentive on what a narrow network can offer and why it's the better choice for them, I think that's very positive. I think to your point about the neighbor, that is how many of us get our physician recommendations. And my mom had her knee done last week, and her husband said, go see my guy. He did a great job on my shoulder. Well, guess what? The shoulder joint and the knee joint are very different procedures. The average joint replacement or the average orthopedic surgeon does 28 joint replacements a year. Lantern wouldn't send you to somebody who does less than 100 knees a year. And that pattern recognition is really important, and you're going to get a better outcome when you go to somebody who specializes. So that incentive in terms of the cost share is really, really important. And then I think we think a lot about coverage. We want to say yes to as many people as possible, and that comes in the form of both the number of procedures we cover, from obviously orthopedics and bariatrics, which are some of the largest cost drivers, but colonoscopies, and that's really about a flywheel effect. Once you get that word of mouth machine going and people hear about what a good experience this is, more people want to use it, and we want to be able to say yes. So in terms of procedure coverage, go as broad as you can, and in terms of the people, don't exclude anybody. We'll do anybody, doesn't matter the age, doesn't matter the stage of a diagnosis, doesn't matter about pre-existing conditions. We would not tell anybody no. So I think that's really important. The other thing that's really important is convenience. Just like when you go out to eat or buy something, you want it to be convenient. And I think we see an 8x increase in member utilization when they can drive to high quality care. So I think the centers of excellence in terms of getting on a plane and going to see for a very complex or rare condition, there is a place for that. But for the vast majority of procedures, there's great care in the community, and we want to get you there quickly and close to home. And then the other thing I would mention is again, just those marketing best practices and adopting some of the things that really get people's attention. We spend a ton of time in terms of data and personalization, meeting members as early in the journey as possible, sometimes even before the journey starts, to anticipate that need so that they're not making a hard decision too much later down the path. We really want to get in front of them early and explain why these decisions matter and how we can help so that they have a great outcome for themselves and the family.
Great. So thank you for that. I think engagement is so important to be able to steer people. I think if you have the best designed program, but if no one engages in it, it's really a non-effective program. So now we have time for one more question. We'll make this a speed round. So I'll start with Dr. MacLean and Dr. Vakharia, if you could follow up on your thoughts. What do you view as the non-negotiables when you strip away the marketing? Whether it be, is it transparency, is it outcomes data, aligned incentives, guarantees, and how do you ultimately know that any kind of program is really delivering ROI?
Yeah, so I think from my perspective as a clinician, and I spent my career in quality, and led the quality operations at then WellPoint for a period of time. I think that transparency is incredibly important in terms of quality. So that it's not just transparency to beneficiaries, but it's also transparency to the healthcare providers who are being measured. And so I want to know, are the measures valid? Do they measure what they're supposed to be measuring? Are they reliable? And are they transparent? And I actually think CMS is the standard bearer in that regard. They test everything, and it's all published. You can look and see exactly what their specs are, and they test it and retest it. And NCQA, likewise. So those are the, to me, the driving pieces. I think we need to measure what matters to people, and I think we're going to see a whole lot more PROMs, outcome measures, in the future. It's taken a while to get that up and running, but I think that we're going to see more of that. And I think that's what matters to patients, is whether they actually get better or not. They feel okay.
Well, thank you, Dr. Vakharia.
I think the non-negotiable is the mindset that you have to go in with, and that mindset has to lead with agency and not sort of feeling powerless around the ability to get control over healthcare spend. I know most people who have to purchase these services didn't go and get a PhD in health policy, and it's pretty overwhelming. But the employers we work with that really have taken control, and they see themselves as architects of building a different healthcare experience, kind of knitting together some of these different solutions in a way that really matters for their members, are the ones who are winning, and they're flattening trend, and they're using that savings to sort of reinvest in other parts of their organizations. And the ones who are like, well, we provide benefits and then we'll leave you to sort of go figure it out, are the ones that sort of year over year I think are frustrated. So I think for me the non-negotiable is that just get in there and figure it out. And then I think the ROI might be, I am a math nerd, but I think it kind of becomes known on its own. It's like that saying, it's like pornography, you just know it when you see it. You'll know your ROI once you really get into it here. And I don't think it's as big of a math problem as sometimes we make it out to be.
All right, well, thank you. I think we're at time now. I wanted to thank the audience and also want to thank our panel for all your insights. Hopefully you're able to take away some nuggets. Thank you.